My name is Patricia, and I'm the program manager with the Epilepsy Foundation. I want to thank all of you for joining us this evening to learn a little bit more about epilepsy, what the different seizures look like, and how to administer first aid. Okay. The objectives for this evening is to know what epilepsy is, what the different seizures look like. Again, no appropriate first aid for each individual seizure type. When to recognize when a seizure is an emergency, because as we all know, not all seizures require a 911 call. And also identify correct and incorrect ways of helping someone during a seizure. So here we go. So what is a seizure? I'm sure you all have seen a seizure. I'm sure you all know how the brain works. We have billions of cells in our brain, billions of cells, all connected with each other. Cells that are constantly sending electrical messages to each other, communicating with each other, controlling everything that we do. Controls movement, controls speech, vision, controls everything. When these cells misfire and send off too much electricity, that is what causes a seizure. Think of our brain, think of it like an electrical storm going off in the brain, just too much electricity being misfired at the same exact time. That electricity, depending on where in the brain it's happening, it can alter movement because some people do convulse. It can alter sensations because some people's seizures are literally just a funny feeling in their stomach. It can alter behavior because some people can act very odd or strange during their seizure. And it can also alter awareness. Some people do lose consciousness. So what is epilepsy? What is the difference between someone having a seizure and someone actually getting the diagnosis of epilepsy? Any one of us can have a seizure, even if you've never had one. Doesn't matter your age, your gender, your ethnicity, as long as you have a brain, the possibility of you seizing will always exist. People have seizures because they overdrank one night. People have seizures because they had a high fever. They're abusing drugs. They took the wrong medication. They might have fell and bumped their head. Things like that can cause a person to have a seizure, just a single seizure. But doctors will diagnose somebody as having epilepsy until they have two or more seizures. 2 or more unprovoked seizures. Keyword there is unprovoked, meaning you didn't have a high fever, you didn't take the wrong medication, you weren't abusing alcohol or drugs. The seizures just came out of the blue. 2 or more, you will be diagnosed. Okay, and also whenever you hear seizure disorder, it's epilepsy. They're both the same exact thing. These are just some facts on epilepsy. About 3.4 million people here in the US have active seizures. In California, about 400,000 people are affected. In our greater LA region, 160,000 people are affected. 1 in 10 people will experience a seizure in their lifetime, just a single seizure, whereas 1 in 26 will actually get the diagnosis of epilepsy. 1 in 26, very, very common, very common. Epilepsy is more common than CP, Parkinson's, and MS combined. Combined, so it's, again, very common neurological disorder. Did you know that most seizures are not medical emergencies? Like I said earlier, more often than not, 911 is not necessary because a person's seizure will naturally end after 2 to 3 minutes, and a 911 call is not necessary. People may not be aware that they're having a seizure, probably won't even remember what happened. Epilepsy is not contagious. It's not something you can catch from hugging someone or kissing someone. You just can't catch it. Epilepsy is also not a form of mental illness. People with epilepsy have a neurological condition, not psychiatric issues. And almost never do people die or have brain damage from seizures. It does happen. It does happen. And Sally will, the second part of the presentation will discuss SUDEP more. I typically ask my audience, how many people can swallow their tongue, but I'm sure you all know that you can't swallow your tongue, that it's physically impossible to swallow. So if you cannot swallow your tongue, forget what your grandmother told you. Common causes of epilepsy. Unfortunately, and I do say unfortunately because the number is so high, but in 60% of the patients, in 60% of the cases, a doctor cannot explain to their patient why they're seizing. 60%. That's a lot of unanswered questions for our patients. How did I get it? Why do I have it? Doctors don't know. MRI scans, PET scans, they all come back and the brain is healthy. There's no scar tissue, no damage, the brain is healthy, yet the cells are misfiring. So there's a lot of unknown, a lot of unanswered questions. More and more though, through research, doctors are finding out that it's genetics. Genes mutate, and that's what's triggering seizures. But for the remaining 40%, the person may have had some sort of head injury or brain trauma. Again, genes may have mutated. They could have inherited an epilepsy gene from their family. They could have had a stroke that led to injury, brain lesions, brain tumors, lead poisoning like lead poisoning, brain infections like meningitis and encephalitis that can lead to damage, brain parasites, which we won't go into tonight because you'll never eat out again. Brain injury at birth. Sometimes if the baby, if child is being born, they can lack oxygen, and that can lead to brain injury. Sometimes the forceps that doctors use to pull the baby out, that can also lead to injury. Or if the brain just doesn't develop normally, that too can lead to seizures. So how is epilepsy diagnosed? First, a person will have a seizure. Then they'll end up in the emergency room. The emergency room will then give them a referral to a neurologist or an epileptologist. Once they're at the neurologist's office, they'll do a clinical assessment, which includes a complete medical history. The doctor will do a neurological exam, order some blood work, and request testing. Typical testing for diagnosis is an EEG or video telemetry, CT scans, MRI scans, PET scans. And once the doctor gets the results from all those tests, the doctor can identify what type of epilepsy you have and then best treat. So we'll now go into the different seizure types. With epilepsy, there's more than 20 different types of seizures, more than 20, but they're categorized into 3, the focal, the generalized, and the unknown. Remember earlier when I mentioned that the cells misfire in the brain? Okay, in a focal seizure, only part of the brain is misfiring, and depending on where in the brain it's happening, that's what your symptoms are going to be. In a generalized seizure, that electrical activity is affecting the entire brain. The entire brain is seizing. Whereas, and also the unknown, where the doctors just don't know where the seizure activity is coming from. So again, there's more than 20, but today we're only going to discuss the 4 most common. First being the absence. I know I can't see you all, but I'm so used to asking questions. For those of you that have not seen an absence seizure, this is what it looks like. Rebecca's on, I think. So Rebecca and I are having a conversation, and I'm having a conversation when all of a sudden I'm sorry, Rebecca, what did you say? I missed that. That is what the seizure looks like. When this seizure first starts, there is a pause in activity. The person will not be able to respond to you. There is a blank stare, so the person will be staring. There's a brief lapse of awareness, so the person will not be able to respond to you. Depending on the person, they can either be smacking their lips or blinking their eyes during the seizure. This seizure only lasts for a few seconds, so they're very easily missed, very easily missed. Literally, an absence seizure can be, and that's it, the seizure's over. Some seizures last a little longer, but they're called atypical absence. They can last about 30 seconds to a minute. This seizure can happen hundreds of times a day, depending on the person's seizure control. And it can be confused with the person daydreaming, not paying attention, possibly being bored, or having ADD. Okay. For this seizure, there is no first aid. Just monitoring how many times you see the seizure happening, keeping the child safe, and reporting that information back to the doctor. Okay. So we'll now move on to the second seizure, and that's the generalized tonic-clonic seizure. This is the type of seizure that you think of when I say seizure, person falling over to the ground and convulsing. When this seizure first starts, you typically will hear a loud yell. It sounds like the person is crying. It sounds like they're in pain, but they're not. What's happening is that there's air trapped in the vocal cords, and because the muscles during the seizure are constricting, the air is getting pushed out. Okay, so you typically will hear a loud yell. The person will lose consciousness and possibly fall to the ground and start convulsing. During the seizure, there will be shallow breathing. A lot of people assume, oh my goodness, they're not breathing, they're not breathing. But if you listen closely, they are breathing. It's just very, very shallow. Drooling can also occur during the seizure because during the seizure, excess saliva is being produced. In addition to a person not being conscious and swallowing their saliva. So there will be drooling. Some people do lose control of their bladder, their bowel. Not everyone does, but some people do. And again, that's because the muscles are constricting. During a seizure, the muscles are very, very tight, very tight. Once a seizure ends, the muscles kind of relax, and sometimes a person can urinate themselves. And occasionally, because of the shallow breathing, the skin, the nails, the lips might turn a little bit blue. But that's normal. It's part of the seizure. Once the seizure ends, normal breathing should resume and the color should come back. This type of seizure only lasts for about 2 to 3 minutes. It may seem like forever for those of you that are not used to seeing them, but really it's just 2 to 3 minutes. And after the seizure is over, the person is in a post-ictal phase, so they might be very confused. They might be sleepy, groggy, they're definitely exhausted, have headaches, difficulty speaking, so definitely expect that. So first aid, what to do during a tonic-clonic seizure. First, stay calm. I know that's easier said than done, but please count, breathe, do whatever it is that you have to do to keep your cool. That person during the seizure really needs you, so please try to keep your cool. Keep track of time. Very important to keep track of time. Any seizure lasting longer than 5 minutes is a medical emergency and 911 is necessary. So please keep track of time. Check for any medical ID bracelets or necklaces. That just tells you that the person is not their first time having a seizure and they do have a history of having epilepsy. Also, keep the person safe. Protect them from any possible hazards. For example, if somebody is let's say that there's a child in the classroom and they're at their desk and they fall over, move the desks, move the chairs, move tables, move everything out of the way, clear the area, just so that they're not banging their arms and banging their legs and hurting themselves. So just clear the area. Turn the person on his or her side. Doesn't really matter which side, just get their body and turn them on their side. That's for a few reasons. One is the possibly choking or aspirating. If you lay somebody flat on their back, flat on their back, and let's say there's a lot of saliva in the mouth, and that's all collecting at the back of the throat. At the end of a seizure, you will typically hear a loud, like a gasp for air. If they have food or possibly vomit sometimes or saliva, they might choke and aspirate on that. So it's very important to turn them on their side so that the saliva or whatever's in the mouth can come out. Second reason you turn them on their side is their tongue. During the seizure, most of the muscles are being used. Most of the muscles are convulsing, except the tongue. The tongue stays in a very relaxed state. If you lay somebody flat on their back, what's going to happen is that their tongue, being in the relaxed state that it is going to go to the back. They're not going to swallow it, but it is going to go to the back and it's going to block the airway. The person will not be able to breathe. Once you turn them on their side, that allows the tongue to just kind of hang there, leaving the airway open. So it's very important to turn them on their side. If the person is on the floor, cushion their head. You have like a scarf or a jacket, just put it under their head, cushion their head. You don't want them banging their head on the floor. So just cushion their head. Loosen any tight clothing that they may have, just make them comfortable. Remain with them until they're fully alert. Typically, I like to ask questions. Do you know who you are? Do you know where you are? Do you know what day it is? Ask whatever questions you want to ask so that you know that person's back with you, okay? Let them know that it's gonna be okay, and call 911 if necessary. Sometimes you call 911 not because of the seizure, but sometimes because of the injuries that the seizures cause. If you have a really tall person and they fall over, they can, crack their head, they can break an arm, dislocate a shoulder. So again, sometimes you're calling 911 not because of the seizure, but because of injuries. An easier way of remembering seizure first aid is stay safe side. Stay with the person, keep the person safe, turn them on their side, and just continue to stay with them to make sure that they're safe. Stay safe side. That's the easiest way to remember seizure first aid. So what not to do during a seizure? Never, ever, ever put anything in someone's mouth during a seizure. We have heard it all. The last thing I heard was when we went to Netflix, a screwdriver. Somebody jammed a screwdriver in someone's mouth. We have heard it all. Again, socks, fingers, shoes, everything. When someone has a seizure, they clench, they bite down, and they bite down very hard. Okay, if you put a metal spoon in their mouth or a wallet in their mouth, what do you think is going to happen? You know, typically you're either going to break somebody's teeth or they're going to injure their jaw. You know, please don't do that. Let them have the seizure. I'm sorry. You know, it's very expensive to pick somebody's teeth, and it's very painful to have your mouth wired shut because your jaw's injured. Yes, a person can bite their tongue. Yes, a person can bite the walls of their cheek, but that will heal. I would rather bite my tongue than have a $15,000 dental bill. So please don't put anything in somebody's mouth. Do not restrain or hold them down during a seizure. You holding them down is only going to injure them. So just let them have the seizure. The seizure will naturally end on its own. Do not attempt to give them anything to eat or drink during the seizure. Remember that the person is not conscious. They're not going to know, oh, wait, let me swallow the pill that you just put in my mouth. They're probably going to choke. So wait until they're fully alert to give them anything to eat or drink. Okay. So when to call 911? When do you call 911? You call 911 when it's a person's first time seizure. They have no history of ever having epilepsy. For that, you would call. If the convulsive seizure lasts longer than 5 minutes, 5 minutes is a general rule. Everyone's epilepsy is different, but 5 minutes is a general rule. You would also call 911 if the person is having seizure after seizure after seizure and is not regaining consciousness, or if a person has multiple seizures within, you know, a short amount of time, whether it be an hour or a day. That's not their usual. You would also call 911 if the seizures change in type. For example, if you have a child who has only ever had the absence, you know, the staring seizures, and one day they fall over and start convulsing, that's an emergency because that's not their typical seizure type. So for that, you would call. If the person is injured, has diabetes, or is pregnant, if the seizure ever occurs in water, even if the person seems fine, please call 911 because you never know if they aspirated any water. Also, if normal breathing doesn't resume after the seizure ends, common sense, you would start CPR by then, but also call 911, or if the person themselves requests an evaluation. So we'll move on to the third seizure, which is called the focal aware seizure, also known as partial seizure, also known as aura. With this seizure, I'm going to show you what the seizure looks like. With this seizure, I'm fully aware. I'm teaching, I'm training you on epilepsy. When all of a sudden, my hand starts to shake. And I know that this is happening to me. I know that, and I'm telling my brain, stop, but it won't stop because there's a misfire in this part of my brain that's causing my arm to shake this way, and it's not going to stop until the misfiring stops. Okay? This shaking is just one symptom of this seizure. When the seizure starts, the full awareness is maintained. A person does not lose consciousness. Again, they can still have a conversation with you. Their awareness is maintained. Some people have rhythmic movement, whether it's twitching of the arms, twitching of the legs, twitching of the face. No, I'm not talking about when your eye flutters. I'm talking about full facial twitching. Some people have sensory symptoms, like they'll feel a tingling going up and down their legs or up and down their arms. Some people will, out of the blue, just feel very tired and exhausted. Some people will hear things that are not there, smell things that are not there, taste things that are not there. Some people get really sharp pains in their stomach or like a feeling of butterflies. Some people, it affects their vision. They will either see stars, just stars, or they will lose their peripheral, or they will lose sight altogether for those 2-3 minutes. Some people have psychic symptoms like deja vu. They will have the same word, same sentence, same thought, just on repeat for those 2-3 minutes. Some people will hallucinate or have an overwhelming feeling of fear that they can't explain. They're just scared. Or they have anxiety all of a sudden. And the most common is a funny feeling that they can't explain. It's like an out-of-body experience that most people describe. So this seizure typically lasts about 2 minutes, 2-3 minutes, and it may be confused with the person acting out because they're scared or having like a mystical experience because they're hallucinating and seeing and hearing things. So for this seizure, there's also really no first aid because the person's fully aware. If they need help, if they need, let's say, a chair, they're going to tell you that they need a chair. So just be as helpful as possible, and keep them safe. So this is the last seizure that we're going to talk about, and it's a focal impaired seizure, also known as a complex partial. I'm going to try to paint a picture with this seizure, just because I can't show you. But we're all learning about epilepsy. When, I'm going to use Rebecca again. When Rebecca gets up from her chair, let's say she's in her office, she gets up from her chair, starts wandering around her desk, wandering around her office, looking confused, mumbling, not making sense, dropping things to the ground. She can be picking at her clothes, and we can be telling her, Rebecca, have a seat. Rebecca, have a seat. And Rebecca has no idea that we're talking to her, okay? Because she's like in a trance-like state. I hope I painted that picture. It's really hard to describe via Zoom. But so for this seizure, awareness is impaired. The person will not be able to respond to you. The seizure often does begin with a blank look, kind of like the absence. So a lot of people do confuse this seizure with the absence. There will be automatisms. So any repetitive movements. So if they're walking, they can be doing this. They can be rubbing their hands together. They can be rubbing their arm. They can be playing with their hair, picking at their clothes, just any repetitive movements. The person will be clumsy, disoriented. If they're walking, it's just aimless walking, picking things up that they shouldn't be picking up, mumbling, not making sense, smacking their lips, doing that a lot. This type of seizure lasts about 2 to 3 minutes. And when the person comes out of the seizure, they're usually very tired, have headaches, have nausea. So it's important that they get rest. This next bullet's actually very important. May become combative if restrained. If Rebecca is in her office dropping things to the ground and she's not listening to us, so we go up to her and we say, hey, Rebecca, stop. Out of natural reaction, because Rebecca is in a very confused state, she's going to want to push us out of the way. Looks like she wants to fight us, but she doesn't. She just wants us out of the way. What it is she's not understanding the restraint that you're giving her because she's in a confused state. She doesn't understand why you're in her space. So let's see, where are we? Maybe this seizure, it can be confused with the person either being drunk or high, because I swear to you, that's what it looks like, or having aggressive behavior if you try stopping them. First aid for the seizure, stay calm. Again, stay calm. Keep track of time. Again, 5 minutes. Let others know what's happening. Let them know that the person is in a seizure and they're not just like misbehaving. Check for any medical ID, bracelets or necklaces. Do not restrain. I repeat, do not restrain. Gently guide them away from hazards. For example, if somebody is walking, let's say you're walking on the sidewalk and a person has this seizure, they can easily walk into traffic not realizing what can happen to them. So gently guide them away from the street. If there's a staircase, gently guide them away from the staircase because they might fall and hurt themselves. If there's a bonfire, same thing. Use your body and your arms as a wall to guide them, okay, away from anything that can hurt them. Do not expect for the person to obey any verbal instructions because it's just not going to happen. And then just continue to stay with them and make sure that they're safe, okay? Until they're fully aware. And again, ask whatever questions you want to ask so that you know they're back with you. We'll now discuss seizure triggers. It's very important to know that everyone's epilepsy is different. Some people with epilepsy have triggers, others don't. And those that do have them, they vary. So let's talk about flashing lights first. Flashing lights are huge. Even people that don't have epilepsy are affected by this. Flashing lights, there's something about flashing lights that trigger seizures in our brain. So now I'm sure you've seen warning labels on video games, haunted houses. You've seen them on Netflix. You've seen them on YouTube. Anything that, if there's going to be flashing lights, there's typically a warning. But with flashing lights, you have kids who are kids with epilepsy who are very photosensitive that, excuse me, that the Fluorescent lighting can trigger a seizure, or the sun can trigger a seizure, or a picture can do it as well. They're very photosensitive. But then you have kids on the opposite side of the spectrum who aren't affected at all, who can stand, who can go to the concerts and go to the haunted houses and look at the flashing lights, and they're not affected. They don't seize. So the flashing lights are definitely a huge one. Other factors that can increase the likelihood of people having a seizure is if they don't take their medication, if they forget to take their medication on time, or just forget to take it altogether. That's the #1 reason. Stress and anxiety can definitely be a trigger. Lack of sleep, if a person's not getting enough rest at night, that'll do it. For females, hormonal changes, especially around their menstrual cycle, hormones can trigger their seizures. That is called catamenial epilepsy. If a person is sick, abusing alcohol or drugs, taking over-the-counter drugs like NyQuil or Sudafed, that can have an interaction with their seizure meds and trigger a seizure. In the summer, or even just yesterday, the heat can be a trigger for a lot of our kids. So, or people, sorry. So if you know that heat is a trigger, it's very important to stay cool, stay hydrated, just stay shaded. And poor diet. If a person's malnourished, that can also do it. Loud noises can do it. Strong smells or odors can do it. This is just a short list. I know we have some board members who have children who they can't show affection to because their child gets so happy to see them that the emotions that they feel, the happiness, will put them into a seizure. So it just depends. Everyone's seizure triggers are different, like I said. And some people have them, some people don't.
Patty, I just want to let you know we have about 2 more minutes for your section.
Thank you, Rhiannon. Types of treatment for epilepsy. Unfortunately, as of this morning, there is no cure for epilepsy. There's just treatment options. First line of defense will always be medications. Most of the time will be medications. There's a long list of medications. Each medication has their own little baggie of side effects. The goal of treatment is to get the person with epilepsy on the right drugs to treat their seizures with the least amount of side effects. That's the goal of treatment. Another form of treatment is brain surgery. Not everyone's a candidate for brain surgery, but brain surgery is an option. And it also depends on, you need to have a focal point, and anyway, you need to be a candidate for brain surgery. I know I have less than 2 minutes. There's also devices, the VNS, the RNS, the DBS also help people, help some, doesn't help others. Talk to your doctor if you're interested. There's also dietary therapies like the ketogenic diet, that diet works miracles for a lot of our kids. A lot of our kids aren't even on meds anymore because this diet works so well. But it's very important, if a parent decides to go this route, that they need to work with a neurologist and a dietitian. But it works miracles. For adults, there's also the modified Atkins, and that is just limiting the amount of sugar that you intake and the amount of carbs. That's also been proven to help. Lifestyle modifications, just managing your triggers. If you know that you can't, drink alcohol, or you need 8 hours of sleep, you need to manage. You need to manage the triggers. CBD is also an option. It's not FDA approved yet, but it's also an option. Talk to your doctor if you're interested. Very important to let your doctor know. Epidiolex is also a CBD that is FDA approved, but right now it's only approved for children with severe epilepsies like the Lennox-Gastaut and the Dravet's. Hopefully that'll change and it'll be available to most people. I know, 30 seconds. We all learned about epilepsy today and the different seizures and how to help, but it's also important to know that there's challenge. People with epilepsy live with challenges. They live with, the side effects of treatments. They have anxiety, depression, social isolation. A lot of them are unemployed, so they do have socioeconomic problems. Yeah, they just have a lot of stresses, and they deal with discrimination and loss of independence. But okay, did I make my time, Rhiannon? This is my information. If anyone would like to get a hold of me to ask me any questions, or you need to elaborate more. But
yeah, perfect.
Okay.
Perfect. Okay, and thank you so much, Patty. And we will be taking questions for Patty's portion and all the other sections at the end of the presentation. Please remember to use the Q&A box. And now we're going to go ahead and bring up our parents, Kim Van Duzer and Allison McKenzie.
Hi, I wanted to see what screen is going to be up. So I am Kim Van Duzer, and this is Allison McKenzie. And I don't know, are there any screens? Our sons are Spencer and Andrew, and Spencer and Andrew were best friends and had been each diagnosed with developmental disabilities and epilepsy at a young age. Both of them were also regional center clients. 2 years ago, they both passed away 4 months apart at the ages of 22 and 21. The cause of death for each was SUDEP, which stands for sudden, unexpected death in epilepsy. Since their deaths, there have been advances in SUDEP research for both the causes and how to reduce your risks.
We're really grateful that you are listening this evening, and we're sharing our story, our personal story with you tonight about our sons and the loss of our sons, not to frighten you, but instead to provide you with information that we wish someone would have shared with us, and to also help you live your best life with epilepsy.
And we've included 2 pictures. The 3 boys are my 3 boys, just to remind you that the journey one person takes with epilepsy is a family journey we all take together. And the picture of the 2 boys are of our sons, Spencer and Andrew, a couple days before Spencer passed. So next to learn more about SUDEP is going to be Sally from the SUDEP Institute. Thank you.
Thank you.
Thank you so much. And Kim and Allison, thank you for coming and sharing about your wonderful boys. I'm sorry I couldn't get everything up right away. For some reason, another presentation kept popping up, but we appreciate you coming and being here and really being the catalyst behind why we are having this right here. These 2 parents want everyone to know about epilepsy and SUDEP so that you can be better armed. So that's why we're here. So thank you, Kim, especially, and Allison as well. We really appreciate you being here and all your efforts. And for some reason, my presentation, there we go. So sorry. Okay, I am Sally Schaefer. I am the Senior Director of the SUDEP Institute. And Patricia and Rebecca, if you wouldn't mind just coming on screen quickly, I have a few questions for you because, like Patty, I like to ask some questions. And one of my questions, Patty, is, and Rebecca, if you're there, is when you purchase something, Patty, do you research it a little bit before you purchase?
Absolutely, I have to.
Okay, well, why do you have to? Let me ask you that. Why do you feel it's necessary?
Because I'm investing my money, and I'm sure if it's something that I'm purchasing for the home, then I want it to be good quality. I want it to last long.
And if you go to the doctor and they tell you something about a condition or something that's happening in your life, do you tend to ask a lot of questions and research it and know about that as well?
Yes, it's just my personality.
Okay. So I think you would agree with me that knowledge is power, right? I mean, the more knowledge you have, the better you feel about what you're going to embark upon, whether it's buying something for your home or knowing about your health.
For sure.
Okay, great. Well, I appreciate you coming on camera again for me to ask those questions. I think the point here is that knowledge is power, and sometimes there's going to be conversations that are hard and uncomfortable, but having that knowledge will help. And SUDEP is one of those things. I am, again, the senior director of the SUDEP Institute, and in a little bit, I'm going to tell you why I'm here both personally and professionally. So let's talk a little bit about what SUDEP is. SUDEP is sudden unexpected death in epilepsy. And I know Patty alluded to this a little bit when she spoke, but this occurs when a seemingly healthy person with epilepsy dies without a known cause. What does that mean? It means that when someone dies, the coroner or the medical examiner look for causes of death. And when they cannot see anything, but yet there was this unexpected death, they then rule this out as SUDEP, especially if the coroner and medical examiners know about it. One such case of SUDEP that you may know in your area is actor Cameron Boyce. He passed away last July from SUDEP. And then also Allison and Kim, who were just here, talked about the losses of their children. So SUDEP is the second leading neurological cause of total lost potential life. And there are statistics that show us about 1 out of 1,000 people with epilepsy die from SUDEP. And the best way to prevent SUDEP, or sudden unexpected death in epilepsy, is to strive for as few seizures as possible. So all those seizures that Patty went over, and gosh, there was more than that even, that Patty, obviously can't cover in this short time, but you want to have as few seizures as possible. So what is the greatest risk for SUDEP? Well, studies have shown that the incidence of SUDEP is higher for individuals with developmental disabilities. And that study was done in 2011, but those seemed higher for SUDEP. And that's why we're here today, to share more about this, not to scare you at all, like Allison and Kim said, but more to give you knowledge, because knowledge is power. And what I'm about to share with you is I want you to take back to your physicians, and I want you to ask them questions about this. I want you to inquire more and find out if your loved one or someone you know is at risk for SUDEP. The greatest risk for SUDEP are people with uncontrolled seizures, and that's why we say to strive for as few seizures as possible. And as Patty talked about, frequent generalized tonic-clonic seizures. And those that have 3 or more increase that risk quite a bit. The other risk factors are if someone has seizures in the evening, or nocturnal seizures, or a long-standing chronic epilepsy, or onset of epilepsy at an early age. So they were diagnosed at a very early age. One of our brochures is called Dare to Say SUDEP, and this is one of the infographics on the brochure. And again, other risk factors that weren't mentioned before are not taking medications regularly as prescribed, or being a young adult. We see higher incidence of death in young adults. It's really important, Patty talked about the triggers, and this is especially important for SUDEP, to reduce that risk by reducing the triggers. So, maybe someone might go to bed at midnight and wake up at midnight at noon the next day, and they're getting that full 12 hours of sleep. But the problem is if they regularly went to bed around 9 and now they were staying up late, they've thrown a little bit off in their schedule, and they probably are throwing themselves off a little bit in taking medications. So it's very, very important to keep a regular sleep schedule, get as much sleep as possible, take the medications, have a healthy diet, go to the doctor regularly, reduce stress, different things that could be seizure triggers. I know you probably are wondering, well, what causes sudden unexpected death in epilepsy? And there has been research for many years going on. Almost 15 years ago, this was hardly spoken of, but now in the last 10 to 15 years, more and more research is happening. Our National Institutes of Health just got done funding research, almost $27 million of research for SUDEP. There are researchers across the world that I talk to and involve and engage with to learn more about what they're doing to solve SUDEP. Right now, when they look at SUDEP, they're looking at areas of the brain that control cardiovascular or respiratory. So is the person breathing okay? Do they have the right heart rhythms, brain functions, or is it a combination of all of this and everyone is still studying this? Advances in research are happening, they really are, and people are working on this in a volunteer basis as well as with their institutions that they work with, hospital systems, universities, and they're looking at those critical risk factors to aid in preventing lives lost to SUDEP. So how can your loved one reduce their risk? I really encourage that people go to an epilepsy center. So within hospitals, there may be a specific epilepsy center or a doctor called an epileptologist. I know that many people see neurologists, and please know that some neurologists are wonderful and great, but an epileptologist has some extra years that they actually study epilepsy. And so I really encourage that you see an epileptologist and that you go to an epilepsy center. I also encourage that you discuss all treatment options with your doctor. Patty talked about some of those. Is it a diet? Is it a change in medication? Is it surgery? Is it brain surgery? Also, keep medical appointments, even if the seizures are controlled. You need to keep seeing your doctor to talk about, are the levels of medication okay? Our bodies change so often, our physiological, everything changes. And so with that, you need to make sure that you're seeing your doctor to make sure you're on the right dose. Is that dose working effectively? Or are there other options to reduce the number of seizures someone is having? Also, ask your doctor about a possible cardiac evaluation. See if the heart is okay. And as we study this and what is causing SUDEP, it's good to know if that cardiac if you need that cardiac evaluation or assistance. And other ways of reducing risk of SUDEP is establish plans for hospital responses for prolonged seizures or clusters. So incorporate the use of rescue medications. Is this a rectal medicine? Is this a nasal medicine? What type of rescue medications does the person need? And make sure those are detailed out. We also have seizure response and action plans, and you want to make sure those are available for anywhere that they are, your loved one is. So is that in school? Is that with another caregiver? Wherever it is, make sure a seizure response or action plan is detailed out on what to do. And definitely involve other people and make sure they know about the epilepsy. And as Patty talked about, making sure the person is on their side and doing that seizure safety. And family members should definitely know about seizure first aid. And seizure first aid is something that the Epilepsy Foundation of Greater Los Angeles offers. They offer that training on how to reposition the patient from a prone position. And it's also been studied at one point that mild stimulation of someone having a seizure may help prevent SUDEP. Now, it is not proven, but that has been one study. My daughter was diagnosed with epilepsy, and whenever she would have a seizure, my husband would always keep her on her back. I think the fear and the anxiousness as she was seizing definitely was there for my husband, but then she would also swallow her own phlegm, which would go into her lungs. So that caused pneumonia. So that is important that you know seizure first aid. People who are around the person living with epilepsy know seizure first aid and can help them appropriately so they get the care they need. I talked about asking your doctor about and talking about SUDEP. If your doctor hasn't mentioned SUDEP as of yet, it may be because of the unknown and the fear. And unfortunately, we find a lot of physicians are not talking about this. That's why we're here today. As tough as this topic is, we want you to have that knowledge. We want you to feel empowered with what we're providing you. And so if your doctor isn't talking about it, these are some questions that you can ask. We have a flyer on epilepsy.com/SUDEP that is called SUDEP, Knowledge is Power. And it is a flyer with all of the right questions that you need to ask. And you can take that flyer to your doctor and ask these questions, such as, what is my risk for SUDEP? What can or should I be doing to reduce my risk? What if I have another seizure? How can I prevent seizures? What should I do to reduce my risk of SUDEP if I have seizures at night? I'm not going to read through all of these, but definitely download that flyer. I'm going to say this, if your physician will not talk about this with you, you definitely need to seek care from someone who will. This is a very important topic, and understanding risk and having these really hard but productive conversations are very, very important. Other questions to ask medical professionals is, should you change the current seizure medications? If we decide to make a medication, what might be better? Are there activities that I should avoid? Activities that would trigger a seizure? I know Patty talked about those as well. What instructions should I give my family and friends if I have a seizure? Should I consider a device? I'm going to talk about devices in a little bit, but should I have a device that could help warn someone? Should I be sharing a bedroom? What else should I know? And another question that's not on here is, does low risk mean no risk? So let's talk about devices as a precaution. Supervision may help decrease SUDEP risk, but devices aren't proven to prevent SUDEP. And devices may actually help with intervening early enough to get care for someone having a seizure. Having someone there during or immediately following a seizure is definitely an advantage, and a device could possibly help with that. And devices are so fast evolving that it's going to play a major role. We had a conference in August, and an individual submitted an idea for a mattress that would actually move someone so that they aren't possibly face forward or face into the mattress. So there are new ideas into the pipeline all the time. So devices for seizure detection are baby monitors. I had a baby monitor up in my room, and I could hear my daughter seizing in her room just by her breathing, and I would wake up. There's also mattress detectors, motion detectors. There are wristwatches that detect jerking. There's one that's approved by the FDA. There's other devices that utilize EEG, heart rate. They monitor sweating, or there's also even motion triggered cameras. There's several that link with smartphones and apps, and some people use a combination of methods. One thing that I want to say is, many people say, I'm not sure I can afford a device. There's many organizations out there that can help do this. The Danny Did Foundation, Danny died when he was 4 years old. They actually help people afford different devices. The Chelsea Hutchinson Foundation is also another organization that help fund seizure dogs or even devices. None of these are perfect for detecting seizures, and none have been proven to prevent, but it certainly gives a peace of mind for individuals that are seizing or their loved ones. Before I end, I'm briefly going to talk about the SUDEP Institute. Our mission here at the Epilepsy Foundation SUDEP Institute is to eradicate SUDEP and support those affected by it. We want to promote research so it ends SUDEP. When I was interviewing for my job, that's exactly what they told me. We want you out of a job because no one else loses their life because of SUDEP. We also want to provide education and awareness, just like I'm doing today. As tough as this topic is, I want to make sure that you know the conversation you need to have with your medical professional to hopefully reduce that risk for SUDEP. We also provide bereavement support if someone would lose someone they love, either through SUDEP or an accident or a drowning or anything else from epilepsy. We want to provide that support to families. Right now, we have many things going to try to help to eradicate and end SUDEP. One of them is a biomarker challenge. We hope to find a biomarker in which we can say is to help prevent SUDEP. The last thing I want to do before I close is tell you that I am also personally affected by SUDEP. My daughter was developmentally disabled. She had a very rare chromosome disorder and was diagnosed with epilepsy at around the age of 3. We tried many different medications, but mainly her seizures were in her sleep. And unfortunately, on Mother's Day 2014, my daughter passed away. But I have not given up. I have not folded. I am here today because I want to empower you with information so that this very scary and hard topic isn't so hard, and that you have the information you need that many families don't ever hear about their loved one living with epilepsy. And so it's very important to me that even though I channel that and I bring it here to you today so that you have that knowledge, and that knowledge is power for you to reduce the risk of SUDEP. So I appreciate you allowing me to be here today, and I look forward to any questions that you have, and I'm thankful to be here. There's many resources. The Epilepsy Foundation of Greater Los Angeles definitely is. We also have a Facebook page. There's also something called the North American SUDEP Registry, and also a conference called the Partners Against Mortality. And here is my direct information if you have any other questions. So thank you so much. And I hope that this was good for you with all the information around SUDEP so that you can go to your medical professional and ask the questions you need to reduce that risk.
All righty, thank you, Sally. Thank you, Allison. Thank you, Kim and Patty. We have a couple questions. One from Jim. Is the mortality rate, this is I think for you, Sally, mortality rate from SUDEP the same with children as with adults?
Years ago, they would say that children were 1 in 4,500. So when I first started the SUDEP Institute, which was 3 years ago, they would say children is 1 in 4,500 and adults is 1 in 1,000. And what they found is that number is the same for both, which is 1 in 1,000. It just hasn't been published yet, but all the researchers have said, yes, that based on what they found, those numbers are 1 in 1,000 people living with epilepsy may die from SUDEP. So it used to be different. You may see data on that if you do any searches, but we're now moving forward with the 1 in 1,000.
Another question, SUDEP more likely to occur in one type of seizure or another?
You are gonna have more of a probability with our tonic-clonic seizures. But I know my daughter's seizures were not a tonic-clonic. And so what I always say is there's not a specific seizure type that I would say. You're more apt with the tonic-clonic, but I don't say that it can't happen with any other seizure type.
Sally or Patty, what is a grand mal seizure? I mean, it's a question here.
Grand mal seizure is just old terminology for the generalized tonic-clonic seizures, the convulsive type.
Thank you. We have a question also about seizure alert dogs. Patty or Sally, if you want to touch upon that.
I think that's information that we can send to them. Sally, I don't know if you want to take it on, but.
Well, it all depends on what that question is. I know people that have had dogs that can detect certain types of seizures. These dogs are often well trained for a very long time so that they can even press a button to make a phone call so that someone can come to help. They can hold the person down with their paws and just lay with them. And so this training is very extensive for a good seizure dog. And I know someone who has epilepsy, and she has a dog. And I know what they did was they swirled like a Q-tip in her mouth so they could, the dog could smell the scent of the person. So organizations like the Chelsea Hutchinson Foundation, I believe there is one out in California too, that where my friend got her dog, and they do this training.
Yeah, we have a great list actually of
Great.
different resources. So please contact us, help@endepilepsy.org. Yeah. Allison, were you going to say something though about, please?
I just wanted to share that we had looked into that for my son, and one of the roadblocks to that, even though he loved dogs, was that he didn't have frequent enough seizures for a seizure dog to be something that would work for him. So it's his seizures were infrequent based on, they were pretty well controlled with medication, but for people who have more frequent seizures, a seizure dog is a really good option. This is just my experience from what I've been told.
Thank you, Kim. We have a question from Cynthia. Cynthia, you've been holding your hand up for a while, so I'd love to get to your question. You want to press what? *6, Rhiannon, to unmute?
No, she's not on the phone, so she should be able to just unmute herself. Cynthia, if you still have your question, you can just go ahead and press unmute.
Perhaps we answered her question, and she just kept her hand raised. Let's see. My daughter has been diagnosed with benign Rolandic seizures. She's not having convulsions. I'm not sure what is the best detecting device. Do you have any advice?
Well, I think that's something that she needs to discuss with her doctor, because benign Rolandic, I mean, typically you have generalized tonic-clonic seizures once in a blue moon, and with benign Rolandic you outgrow your epilepsy. But if you want to, I feel like every monitor has its purpose. Like some of them's a watch, some of them's on a mattress. It just depends, but I would definitely talk to the doctor. I hope that answered your question.
The other thing they can do too is you could reach out to organizations like Danny Did Foundation. While they may not give specific, recommendations because they're not physicians, which I think, Patty, you're so right, it's the physician. But if the physician doesn't have a lot of knowledge of devices, talk to different organizations. Maybe they can recommend people that they've known have certain devices. Again, they can't give medical advice, but maybe just even knowing someone else who has that type of seizure and what device they're using might be able to help or steer you.
All right, I'm not seeing any other open questions, but please know we are here for you, the SUDEP Institute, our local Epilepsy Foundation. Appreciate you all so much for joining us, and thank you for the panelists for joining, and Kim and Allison for sharing your personal story. And then I think that's it, but you're not alone, we're here for you, so please reach out.
Thank you, Regional Center. Thank you, parents. Thank you, everyone.
Thank you. We will send the recording out, so if you want to rewatch it, you'll be able to do so, or share it with anyone who may have missed this training tonight. So thank you to all of our amazing panelists. We appreciate you and the incredible knowledge that you have shared with our community, and we hope everyone has a lovely night. Thank you.
Thank you.
Bye.
Bye.
Bye.